Satish Velati.
Yes, so we are live on the YouTube. We wait for 2-3 minutes more.
Okay. Should I share the screen, sir, or after?
No, I will introduce you and then you can share the screen. Let us wait for 2-3 more minutes.
Yes.
There will be many pediatricians who will watch this talk on YouTube later on.
Yes, sir.
My friends tell that in the morning it is difficult, but we
Yes.
do see the things later on.
Yes, sir.
And this is of in interest because these guidelines have come very recently after
Yes,
so
sir.
many years.
And UTI is something all see like in the
Yes, so
practice.
common, so common.
Then like that stuff is there. So, yes, sir.
Today you will have more time, Jalpa, because it's 40 minutes talk. So
Yes, accordingly we'll do that. Yes, sir.
okay, so we start now. It's already 3 minutes past 8 o'clock. Good morning, friends. Welcome back to Saturday Club meeting. Today we have a very eminent pediatric nephrologist, Dr. Jalpa Dave with us. She has been our guest speaker several times in the past. She has done her fellowship in pediatric nephrology and working as consultant pediatric nephrologist in Vadodara. She is affiliated to KGP Children Hospital, Parul Sevasram Hospital, Vadodara. Her areas of special interest are critical care nephrology, glomerular disease management of KECOT. She has several publication presentations and prizes at national and international levels to her credit. And of course, she is a very popular speaker at various academic fora in India. So over to Jalpa for talking to us about recent guidelines on management of UTI in children. So over to you, Jalpa.
Thank you, sir. Uh, Thank you so much for the generous introduction, sir. It's always pleasure to present at this Saturday Club meeting because I feel it's one of the example of how a good determination can go long way with good leaders with them. This program is, I guess, since years it is providing opportunity to people, especially medicos, to share their views regarding academic as well as non-academic events, and it's a pleasure. Thank you, sir, for inviting me at this forum. Uh, so the topic for today I have selected is urinary tract infection, recent guidelines and update in pediatric. I feel, and we all know this is a very common sentence we come across that children are not midi adults. The same way you cannot cut pant of pant in a half and give it to kid. Similarly, you cut the tablet half and prescribe to kid. But yeah, children itself are a kind of they have their own approach to any particular disease. They have their own treatment and they have their own guidelines to treat. Not very similar. It is definitely there will be some similarities, but they do have specific guidelines and management for various disorders. Healthy kids grow into healthy adults. I feel that, just like teachers are responsible for forming a youth of like a good youth of a nation. whenever we think, we all must have some kind of, teacher that whom you see in your childhood, that okay, I want to follow his ideology or his thought process. So what I feel, we as pediatrician, along with pediatric specialties, have the responsibility to grow the kids with in a healthy adults. The habits which we kind of incriminate in them, the lifestyle habits, the way we treat the diseases in the tender age, do have very much implication in their health in the future when they become adult. And Satish sir also must be knowing, nowadays we have the, the transition of care, that we should hand over to our colleagues, adult colleagues, in a better way. So if we have treated and incorporated healthy habits, healthy treatment in very of the common diseases, good vaccination, then all these kids of our nation can become a healthy adults, not only a wealthy one. And certain diseases in pediatrics do have long-term effects in adult life. It is a well-known fact that IUGR babies or preterm babies do have more tendency to develop sometimes hypertension in adults. Similarly, many of the infection, like especially what we are going to talk about today, that is urinary tract infection, how it is treated in younger kids, do have long-term effect, how their kidney will behave when they become adult. So, not wasting much time, why to know regarding pediatric urinary tract infection is, upper tract urinary tract infection in children can lead to scars in kidney, which is usually irreversible. And recent data suggests that almost 7 to 20% of chronic kidney disease, like those kids who ultimately require dialysis, are because of reflux nephropathy, which can occur because of recurrent urinary tract infection with primary vesico-ureteric reflux. So, it is must to identify UTI in pediatric age group on earlier basis and treating them accordingly. And it is not very uncommon. Almost 2% of boys and 7% of girls do experience at least one episode of UTI less than 6 years of age. The symptoms as well as the management can vary along with individual case, which we will see in upcoming slide, that all UTIs are not simply burning micturition and increased frequency. Pediatric UTIs do have different wide spectrum of presentation in particular patient. And this is very important, that we call medical science as a practice for a reason. We are kind of updating ourselves throughout our career with new research and guidelines available. We do need to keep ourselves updated and be knowledgeable about what are the recent guidelines in any disease management, depending on the new research is going on. So the outline of my today's talk will be, we'll go through the definition, like how is the pediatric UTI is defined, the diagnosis of the same, management, how you can prevent scarring, which is sometimes irreversible if not given attention to, something regarding bowel bladder dysfunction, which is very important nowadays because of poor choice of bad, bad habits or lifestyle. And last but not the least, few words regarding management of vesico-ureteric reflux in pediatric age group. What I have done is I have just included few case scenarios to make it more interactive, because I feel guideline is something, it is more of a theoretical. So I have tried my best to include some day-to-day life like case scenarios in our OPD practice, and to know how we can implement the guidelines along with this in our practice. So first snippet is, this is a very common thing that you come across, especially as a physician as well as pediatrician, that a 2-year-old male child who had presented with complaint of fever for 5 days, with urine routine showing 10 to 15 pus cells, urine culture showing E. coli in the 10 to 5 colony forming unit per ml, which is almost according to the definition, it is significant. Leukocytosis, raised CRP, the boy did had crying while micturition present. There was increased frequency of urine. No other focus of fever is found. And examination, when done systemically, generally everything was kind of within normal limit. Pardon me for that short form actually. So, is this UTI? Yes, this is a kind of classic case of urinary tract infection, which we see in our day-to-day practice. Similarly, another example, a 5-year-old female child who is a known case of bilateral pelvic dilatation secondary to partial pelviureteric junction obstruction. She had complained of fever and cough for 2 days. There were no urinary symptoms per se, but because the USG was suggestive of pelvic dilatation, urine routine was asked for. So urine routine showed 10 to 15 pus cells, but culture which was sent showed no growth. So can it be UTI? Actually, no, this is not. We won't label this as a UTI. Why? We will come later on with the definition. Another case scenario, a 2-month-old male child with fever for 5 days, with poor feeding, vomiting, lethargy. The boy is just 2 months old. He's not going to tell you regarding any of the other symptoms regarding picturing, burning, etc. The parents have not noticed whether there is any change in the habits of his maturation. Urine routine was not obtained. It was very difficult for them to get a urine routine of an infant. Chest X-ray was done. It was within normal limit. And the antenatal scan of this baby was suggestive of hydroureter and hydronephrosis. So can this be UTI? Yes, though there is, it's very, there are no specific urinary symptoms, but looking at the hydronephrosis, hydroureter, and age of the child, poor feeding, yes, this kid too can have UTI. The last scenario, a 4-year-old child, known case of neurogenic bladder secondary to myelomeningocele. There is no complaint of fever or dysuria as such, but as a part of routine follow-up, they gotten his urine routine, which showed 10 to 15 pus cells, and culture showed Proteus mirabilis of 10 to 5 CFU and E. coli of almost 10 CFU. So can this be UTI? No. You can label this as an asymptomatic bacteria, but this is not considered as a UTI. So, what is the definition of urinary tract infection? Urinary tract infection is defined as a growth of single uropathogen with significant colony count in the presence of symptoms. So, if we declutter the definition into parts, then what is significant colony count for pediatric patient? So it depends largely how the sample has collected and whether it has been transported adequately with adequate measures and all. So unlike in adult, it's very easy to tell them that, okay, collect midstream sample. But in pediatric, to collect a urine sample, especially in young children, is indeed a mammoth task. We just say, but it is, when your own kid, you need to give sample for your own kid, and then you will realize, oh, it's like really it takes lots of time to get a midstream sample for a kid, especially who are young. So how we can collect in pediatric? So one of the very earlier we used to use this method a lot. Many times still few centers still using this. That is suprapubic aspiration. That just above pubic symphysis, say 2 to 3 centimeter, you can puncture at almost 10 to 20-degree angle of your vertical line. But nowadays it is not very acceptable to parents because it's a bit invasive method. And we do have few other things available. Like the other option rather than suprapubic is simple catheterization. You can insert an infant pubic tube with all aseptic measures to collect sample if midstream is not available that easily. And the most common method which is used in adult as well as older children is clean catch midstream sample. Like you ask them that, okay, you don't collect you clean the genitalia with simple water and soap and then collect the midstream one. Discard the initial few drops and midstream you should collect. In infants, it's very difficult because you never know when the baby is going to pee. So there are few things what I usually do in my practices. Mothers know, the each and every baby has a particular pattern. So she knows that, okay, my baby usually say after giving her or him breastfeeding, after 10 to 20 minutes, they do urinate or micturate. So you can tell them that, okay, you take 2, 3 container with you at home and keep it aside. Whenever you feed the baby, keep her or him open. And whenever he passes urine, you can directly take it in container. Or else you can use this one of the quick V method. If you apply a very cold gauze paste over the suprapubic area and rub it for a time, then because of that reflex contraction, the baby can pass. So this can be used for collecting midstream or clean cat sample in younger children. And I feel this is more, it should be more uh, commonly used rather than catheterizing and all, but ultimately it's all depend on the patient. So what is significant colony forming count is that we all know that suprapubic aspiration method is the ideal one. So if it is there, then even single number of pathogen, that is more than or equal to 10 raised to 3, will be defined as a UTI. In case of catheterization, more than or equal to 10 raised to 4 colony forming unit. What is CFU? It's basically one of the unit microbiologists use to quantify the bacteria, how much bacteria they have grown. So in case of catheterized sample, it is more than 10 raised to equal to 4. There is some difference in the clean cat sample cutoff, that earlier we used to take more than or equal to 10 raised to 5 as a cutoff for defining UTI. But they have observed that especially in young children, the blood time is not that long. So you may not find so much of growth in spite of having urine infection. So they have down the cutoff to 10 raised to 4, especially for younger children less than 2 years of age, for clean cat sample as well. So this is one difference. Now the second part of the thing, how to transport urine. It's very important that the urine should be transported at least within 1 hour at room temperature, or if you have some delay in transporting the sample to a lab, then you should refrigerate it. But that also can be done only till 3 to 4 hours. You cannot refrigerate the sample whole night, or say for 6 to 7 hours. You collect the sample in the morning and go to the lab to give that evening. So ideally, it has to be fresh, collected, or it should be transported correctly. Coming to the second part of the definition, what is the clinical symptoms? As we saw in the previous case, that adults, the most commonly the urinary, like dysuria, burning micturition, crying while passing urine. But in case of kids, it will be like crying while passing urine, or there can be change in the frequency. Like there can be like increased frequency, polyuria, or so, or decreased frequency. Or it can be hematuria, cloudy urine, malodorous urine, though they are not very commonly seen. Or even urge incontinence is sometimes seen along with the urinary tract infection. But in pediatric, especially in younger children, they do present sometimes with only systemic effects of the UTI. They don't present with the urinary symptoms. What they present is fever, vomiting, poor feeding, loose motion, lethargy, etc. Pain in abdomen. Again, I want to stress that usually UTI does not lead to pain in abdomen until and unless if you are suspecting a pyelonephritis or there is associated bowel bladder dysfunction and constipation. Then that can be the reason for pain in abdomen. But typical complaint which many kids do have, that relatives are like, Madam, पेट दुखे છે, urine માં છે એટલે urine infection છે. Pain in abdomen is not that commonly seen with UTI until and unless you are thinking of some level of pyelonephritis or there is associated constipation. Failure to thrive, jaundice, hypothermia. This is mainly for newborn UTIs. It is not seen in older kids also. And loin pain and tenderness in case of, again, pyelonephritis. That is upper tract urinary tract infection. So what all things you will look for examination when a patient, especially pediatric patient, come to you with even first episode of UTI is, in vitals, you will check for blood pressure, because many a times reflux nephropathy kids can have blood pressure as young as 1 or 2 years of age. In general examination, you will look for short stature. Why? Because many of the congenital CACID, that is congenital anomaly of kidney and urinary tract, can have effect on growth. So you need to take height. In other general examination, you will look for back and spine to know the scar of any MMC, that is meningomyelocele repair done in past, or even for to look for the red flag signs, whether there is a hair over there or some swelling over there in the back and spine, especially lower lumbosacral spine region. You will also look for the anal tone. In genitalia, in male, you will look for phimosis, poor stream. In female, one of the very important things is vulval synecdoche, which is very commonly missed. because usually all will check the male for phimosis, but nobody will like to check a girl kit for synechium, which is very commonly associated with girl UTI in younger age. So one has to look for vulval synechy. And in systemic examination, you will look for palpable bladder in case of posterior urethral valve. Palpable kidney is very rare unless you are suspecting some unnoticed PUJ, that is pelviureteric junction obstruction. Fecolith, sometimes the kid can have such a bad degree of bowel bladder dysfunction and severe constipation that you can literally palpate the feces while doing per abdomen examination. And in neurologic examination, I would like you to check also for reflexes, especially knee jerk and all. If it is brisk, then you should suspect a neurogenic bladder as well. So these are few points you will look for on examination. Coming to sample, we all saw in the definition the specific and gold standards test is urine culture. We all have to do. But what about the screening test? Because urine culture takes at least 48 hours for even the simple report to come. So during that time, the screening tests which are used, either you can use the dipstick method, that uses the bacteria which produce the enzyme, that is leukocyte esterase and nitrite method, or the more commonly used by all people in office practice is urine routine microscopy. So the new guidelines released by ISPN, that is Indian Society of Pediatric Nephrology, have really given very good flow charts how to go about, including every detail. So if you see in the flow chart, if your patient baby has fever without focus for more than 48 hours, especially if the baby is less than 2 years, or there are presence of risk factors for UTI. Now, what are the risk factors for urinary tract infection in kids are? If there is associated constipation, if there is known case of primary vesicoureteric reflux, or there is previous history of UTI. So all this, or if the baby has urinary symptoms to begin with, then you will give culture. You cannot miss giving urine culture. Urine culture is must. But apart from that, while awaiting urine culture, you will ask for either dipstick or urine routine micro, depending on availability locally. So if your dipstick test or your urine microscopy is positive, then you will start empirical antibiotics and wait for culture. If your culture comes negative, you can stop it. If it is positive, you can continue antibiotic and see. If your urine routine microscopy and your strip test, that is dipstick test, is negative, but if you strongly feel that there are risk factors for UTI or the baby is too young, then they suggest that, okay, you can empirically start antibiotic in spite of negative screening test, because all this urine routine micro and urine dipstick have their own limitation depending on the sample collection and all. And start antibiotic, wait for the culture. If culture is no growth, you can stop. If culture comes positive, you have to continue with antibiotic. Coming to how will you treat UTI in the office practice as well as indoor, especially this is regarding pediatric UTI, it depends on age of presentation, severity of illness, site of infection, that is upper tract UTI or lower tract, that is mainly involving bladder and all, or presence of associated congenital anomaly of kidney and urinary tract, and local antibiotic sensitivity pattern. And I have divided into the specific or primary treatment of that particular episode, followed by what are the preventive things you should do to prevent a second episode. That includes imaging and chemoprophylaxis. So this is another snippet. This is a 2-month-old female child who presented with fever and lethargy with urine showing 10 to 20 pus cells. Culture was awaited. Will you admit this kid? I feel that yes, because the baby, though the pus cells are very less, but if you see the age is 2 months, already the baby is lethargic, and this baby cannot be managed adequately for danger signs of upper tract UTI, etc. in home. So you should admit the kid. Similarly, a 6-year-old boy with fever, burning micturition, the urine showing 500 pus cells, culture awaited. But with the same, though the pus cells are more, you are not going to admit this kid, because ultimately he's a big enough boy who can take oral antibiotic and you can deal with the UTI. So no need for admission. So this is a very good flow chart to know when to admit, for how many days to give antibiotic, etc. So urinary tract infection on the left side, if it is cystitis, that is lower UTI, then you will treat just like any adult people. Like you will give oral antibiotic for at least 3 days or 7 days if required, depending on the culture and the response of the baby. But if there is a febrile UTI, that is upper tract urinary tract infection or pyelonephritis, again, they feel that in young children less than 2 years of age, it is any febrile urinary tract infection is considered as pyelonephritis until proven otherwise. And if your patient is less than 2 months old with bad sepsis, with renal angle tenderness, with poor oral intake, then you should admit it. You should give IV antibiotic for 3 to 4 days. If your baby is responding, you shift to oral within 4 days, or if it is not responding, you resend the culture to evaluate. You repeat USG to know whether the UTI has complicated, whether there is formation of renal abscess or pyonephrosis or any associated cacket, etc. If your baby is more than 2 months of age, not very bad sepsis, so though febrile UTI, you can take a trial of oral antibiotic. So when to admit all those kids having UTI who are less than 2 months of age, who are very severely ill, or who are not able to take oral antibiotic for some reason. Now, what antibiotic you will give is the duration and choice of antibiotic depend on the antibiotic of choice, still the same like it was previously, that is either third generation cephalosporin or amoxicillin. The duration of antibiotic depends whether it is an upper tract or lower tract. In case of upper tract UTI, ideally, even in pyelonephritis, if the baby has responded well, it should be only 7 to 10 days. But if there is some complication, say renal abscess or something, then you can prolong the course. In case of cystitis, it is usual minimum 3 days and maximum 7 days, not more than that. So no need to give antibiotics say for 14 days because urine culture is positive when the baby had no fever on second day of antibiotics. So there is no need to give prolonged therapy for normal UTI patients. This is a very important finding which say that it doesn't matter whether you give 7 to 14 days of IV antibiotic or you give only 3 to 4 days of IV antibiotic and then shift to oral. So there is no rationale in keeping these patients giving IV antibiotic for as long as 7 to 10 days when there is no complication, no abscess or anything, right? So this is very important. Now, as I said, after treating the current episode, what you should do is you should do some investigation and some actions to prevent the further scarring or to avoid the second or further episode. So it includes imaging and role of chemoprophylaxis. So imaging, we all know ultrasound, micturating cystourethrogram and DMSA scan. Ultrasound is ideally should be done in all pediatric patients, no matter what age it is, 1 year, 5 years, 6 years, 10 years, 12 years, 13 years. But if there is a first episode of UTI, all this patient has to go for ultrasound to rule out any associated congenital anomaly of kidney and urinary tract. And ultrasound has to be the detailed one. It is not simply, okay, kidney size is normal, urinary bladder is normal. It should include how is the echogenicity of the kidney, whether there is pelvic dilatation, whether there is hydroureter, how is the bladder, how much is the post-void residue in a bladder. So all these things should be mentioned in the pediatric ultrasound KUB. What about MCU? Micturating cystourethrogram in adult is very easy to do. You just advise them accordingly and it is the office procedure, say lasting only for 10 to 15 minutes. But to order a micturating cystourethrogram or MCU in a pediatric patient is definitely not a very easy thing to convince parents for. Ultimately, you are going to catheterize the small baby. So much of mental trauma for the baby as well as for the parents. So they have revised in whom to do MCU, and apart from that mental trauma, the radiation which is involved with this procedure also counts. So what they have done, this is few snippets, 2 or 3, which we will discuss, in which you will do order MCU, in which you won't. So suppose a 2-year-old female with febrile UTI with Escherichia coli who required oral antibiotic and get settled. Her UIC is normal and it was first episode. Will you do MCU in this case? No, there is no need to do MCU because it was a simple UTI with normal USG in a 2-year-old kid. At the same time, if there is a 8-month-old male with antenatal scan suggestive of bilateral pelvic dilatation with first episode of UTI, if USG showed raised echogenicity, then yes, you will definitely subject this kid for MCU. So this is a very good flow chart. First, we'll see with first episode of UTI in whom you should do MCU. As I said, ultrasound is all. MCU, if your ultrasound is abnormal, definitely you are going go for maculating cystourethropy. But if it is normal, you have to do a close follow-up. But there are certain cases in which even with the first episode of UTI, you will ask them to go for MCU. Who are those are? This is again one simple, that is 3-year-old male child. But if it is second episode and culture is Klebsiella, then you should ask for MCU, though the age is 3 years. And similarly, if the baby is 9 months who responded, her culture showed E. coli, first episode of UTI, but USC was normal, then you can safely don't do MCU in this 9-month-old kid. So this is a complete flow chart. In first episode, if there is ultrasound is abnormal, you do. And there are few first episode of UTI, like if it is non-Escherichia coli UTI in less than 2 years of age, or there is recurrent UTI. Recurrent UTI means more than or equal to 2 episodes of UTI, you will straight away go for ultrascan as well as MCU. Regarding DMSA scan, one should never ever do DMSA scan when the baby is having active infection, because whatever you will find some scarring here and there, ultimately you need to repeat it after 4 to 6 months to know whether they were permanent scars or not. So even DMSA scan is not free from radiation completely. So please don't advise DMSA scan at the, we should not advise it during the time of infection or as early as say 1 to 2 months of infection. It should be done after 4 to 6 months of first episode of UTI or any episode of UTI, right? So it's a very good table. And here I have marked the arrow, that is red arrow. The assessment of bowel bladder dysfunction is really important, and why will come in a next slides. This is just an example how you grade vesicuretic reflux. So the International Reflux Study Grading Scheme shows that if the reflux is in a non-dilated ureter, it is grade 1. If it is into the renal pelvis without dilatation of ureter, it's grade 2. If it is associated with mild to moderate dilatation of ureter and pelvic system, it is grade 3. If it is dilatation of renal pelvis along with a mild tortuosity, along with, kind of starting of blunting of cheilitis, then it is grade 4. And grade 5 is definitely gross tortuous ureter with blunting of cheilitis, in fact, convex cheilitis, loss of papillary impressions, etc., etc. So what they have done in this guidelines is, low grade VUR are those of grade 1 and 2, high grade VUR are those grade 3, 4, and 5. Something regarding chemoprophylaxis. Chemoprophylaxis is when we give antibiotic in low dose on a daily basis, so that that won't be a episode of UTI, presumably. Almost it is effective almost at the rate of 70 to 80%. So these are few snippets. A 3-year-old male kid with febrile UTI with grade 1 vesicuretic reflux. This kid, do you give chemoprophylaxis? No, this kid without any other complaints with low grade VUR, you should not. Similarly, a 4-year-old female with febrile urinary tract infection with grade 2 VUR with constipation. So though there is a low grade reflux, because there is associated constipation, you should give chemoprophylaxis till the girl come over the constipation thing. Similarly, a 7-year-old kid, though he is more than 5 years, if there is recurring UTI with constipation, even with grade 1 reflux, you should give chemoprophylaxis. All the snippets I have included are basically a normal scenario, so it is not a thumb rule. You have to evaluate each and every patient individually to know in whom to apply what guideline. So indication of chemoprophylaxis in nutshell in pediatric UTI is, if your patient is having high-grade primary vesicuretic reflux, or if there is recurrent febrile UTI and bowel bladder dysfunction, even if the patient is not having any reflux, if there is recurrent UTI with constipation, you should consider chemoprophylaxis. This is a change in the guideline. Similarly, whom not to give? All those antenatal hydronephrosis babies, while there is no hydroureter, simply almost 80% of antenatal hydronephrosis without hydroureter and PUJ obstruction. So you should not subject those little newborn kids to unnecessary antibiotic if you are not suspecting reflux, and whom not to give is low grade reflux with normal USC and without constipation. So grade 1 and 2 reflux, which we used to previously give chemoprophylaxis, should not receive it. And when to discontinue chemoprophylaxis? For all the children who are more than 2 years of age, if they satisfy all three criteria, like they have achieved toilet training, there is no bowel bladder dysfunction, and there is no precedent UTI in last 1 year. So say if you have a patient of 4 year of age with grade 5 reflux, if there is no UTI in last 1 year and if there is no constipation, the guy is having healthy habits, then you can omit the chemoprophylaxis for him. Which medicine to be given is same, that is for treatment I have already mentioned, and for prophylaxis that is cotrimazole and nitrofurantoin for older babies more than 6 months or 3 months, and cipralexin for those less than 3 months of age. Now the bowel bladder dysfunction, we have in last few slides there was constant, you know, this thing regarding bowel bladder dysfunction, it was constantly discussed. So what is it? It is common in children with urinary tract infection, and it comprises of a spectrum of lower urinary tract symptoms in the presence of constipation and or encopresis. So it's basically kind of because of a bad bowel and all, the overall dynamics of bladder can get affected, and it can either become overactive bladder or lazy bladder. So nowadays, because of junk food and many other bad habits over screen time, etc., the kids do have habit of holding back urine, not going immediately using washroom. All this thing can lead to complex interplay between bladder and bowel, and it can lead to bowel bladder dysfunction, which can manifest with recurrent UTI. So this is one case. A 10-year-old female with recurrent UTI with occasional urge incontinence, with history of constipation, her MCU with presented with infection, that is UTI, with normal sonography and MCU suggestive of very low grade reflux, that is grade 1. So what you should do? You should definitely treat the first step like the UTI with oral antibiotic. But the detailed plan for this girl should involve voiding diary. It should involve treatment of constipation and urotherapy. So voiding diary is very useful in pediatric patient when you should not subject each and every pediatric patient to uroflowmetry. Rather, a simple voiding diary can give you an idea about how his or her bladder works. And I have seen that in my practice also, if you advise the parents correctly, then they definitely make a very good voiding diary of their kids along with the help of kid and themselves, and they also feel involved in management of their kids. So voiding diary is very important for all those patients with lower urinary tract symptoms. So this girl's voiding diary showed me that she was having overactive bladder with low capacity. So what is urotherapy? So what I feel the urotherapy includes voiding diary, which is made every week or 10 days to assess the response to the urotherapy prescribed. So it includes lots of water intake. It's nothing but a good behavioral habits. So lots of water intake, around 3 liter per 1.7 body surface area. No to junk, yes to greens, no to preservative containing foods, maida products, biscuits, this, that, all those stuff. And yes to green. Adequate posture, which is very important in especially in younger kids, because if they don't feel safe while using the toilet seat, they won't evacuate the bowel in a perfect way. So they should be given a stool so that they feel safe while using Western toilet. Similarly, frequent voids, like every 3 hourly, they should, if the baby is busy playing games or in TV or mobile, you should remind them that, okay, now it's more than 2-3 hours, you have not use washroom. So frequent voids, double voids, that is, you can ask them to wait or count 1 to 10 while standing in washroom, and then again try to pass urine. So whatever post void is there will come out. So this is regarding urotherapy. The other management after urotherapy is treatment of constipation, dietary as well as medical treatment, use of polyethylene glycol, etc. And second line, it is the last. Usually, I don't need to use anticholinergic drug if urotherapy is followed properly. So this is just for a theoretical aspect, that the first line for bowel bladder dysfunction is urotherapy bowel, followed by SOS need of few medicine, which I don't think that commonly should be used in pediatric population, followed by third line. It should be used with proper expertise and proper monitoring. So it should not be used at the first line level. The last few slides regarding management of vesico-ureteric reflux in pediatric and when to invite surgeon. It's always in our nephro-uro conferences, there is always, you should operate, you should not operate. So the flow chart we have given, it's really nice flow chart. So if your baby has primary vesico-ureteric reflux, on the left side you can see if it is low grade reflux of 1 or 2, there is no UTI, then ideally that kid doesn't even require antibiotic prophylaxis. But if there is UTI or there is associated bowel bladder dysfunction, there is severe constipation, then yes, you should give antibiotic prophylaxis, but surgery is not advised. If there is a high grade reflux, say grade more than grade 3 or 4 or 5, the first option should be given ideally is antibiotic prophylaxis, irrespective of there is constipation there or not. But on antibiotic prophylaxis also, if there is recurrent UTI, then you should give them an option of surgery. Surgery can be done either it is reimplantation, the definitive surgery, or nowadays they have this endoscopic injection of Dixil material. So what they do is, with the help of, as a part of daycare procedure, with the cystoscopy, they do inject the gel just below the ureteric opening. So it will, kind of slow down the reflux and decrease the intensity of reflux. Though it is not a permanent solution, sometimes you need to revise it 2 or 3 yearly. But in Western countries, they are more using this Dexel, but here still reimplantation is more commonly used. And one more point which they have mentioned is, if the parents don't want to give long-term antiprophylaxis, then yes, they can straight away go ahead with the surgery. This is last slide, and this is not from the guideline per se, but this is my own thing, and I wanted to convey the message. This is from our textbook of pediatric nephro, that all those primary vesicular reflux are not having acquired reflux nephropathy. There are few subset of patient, if the kid is just 1.5 or 2 year of age, who had not a single episode of UTI with grade 5 EUR, if you do DMSS scan, the function is 10%. Though there is not a single episode of UTI. So all those kids fall into the criteria of congenital reflux nephropathy. So it is not UTI which is leading to the nephropathy, but they are like this to begin with because it was prenatally onset and dysplasia and all. So all this patient won't get any help from unnecessary undergoing reimplantation surgery. Because even if you do surgery after 2 years, if you repeat DMSS scan, the function might have reduced from 20 to 10. And then they will say, madam, like whatever that you had operated and still the function is down. So all those patients, it's very important to differentiate between the acquired reflex nephropathy and congenital reflex nephropathy. These are few common, sir, should I continue? It's last few 3 slides.
Yes, we have time. We have time.
Okay.
Go ahead.
Yes, sir. So these are very few common queries which parents ask you in your, even relatives of you can ask during the social gathering, which we are subject to daily, that, okay, my baby or this thing has recurrent UTI, should I give them cranberry juice, etc. So yes, cranberry juice, because of that element, they do have some effect on preventing UTI, but that is if it is given in a very large amount, say almost 300 to 600 ml of cranberry juice can have some effect on preventing UTI. So technically in India, it is not a very good thing to advise them. Unnecessary, it will be a burden to them. So yes, but to act as an effective measure, it has to be taken in very large amount. Another queries from parents is circumcision will help to prevent UTI? Actually, yes, but it is only till 1 year of age. So a 4-year-old baby with, not that bad phimosis, you should not advise to go for circumcision just because it is having some UTI. You should rule out the other factor like constipation, bad toilet habits, etc. Some physician or pediatricians' common queries are, do we need to screen siblings with primary vesicular reflux? Yes, those who are less than 3 years of age, like if you have a patient who has got grade 4 reflux and he has a sibling who is 2-year-old, ideally you should get them one sonography, because primary vesicular reflux can have occurrence in sibling as well. Do we need to treat asymptomatic bacteriuria? No, unless you are planning for some urological procedure involving some bleeding in locally, like cystoscopy is planned, then you should treat it. Otherwise, never ever treat asymptomatic bacteriuria, or in case of adult, in pregnancy. So we do not suggest use of antibiotic for treatment of asymptomatic bacteria in pediatric unless few exceptions. And this is very important that routine urine culture should not be performed in asymptomatic children, because there are so many confounding factor with the culture report, that if your baby is asymptomatic but there will be like any proteus or Burkholderia, this kind of organism, and then you will get confused whether to treat or not. So ideally, if there is no symptoms, just to have normal follow up, you should not do routine urine culture. And when to repeat MCU? Ideally it should not be repeated every 2 or 3 yearly to know the grade of reflux, because it is not going to change management at all, but you are subjecting the kid to unnecessary radiation. So it should be repeated only after 4 to 8 years, and that also depending on the cases. So to stop chemoprophylaxis or to decide about this thing, you should not keep subjecting the child to this traumatic procedure so frequently unless indicated. At the same time, I would like to clarify that those kids who require MCU, you should counsel the parents that it is important to prevent reflux nephropathy. So for those, you have to go for, but you should not do it like every 1 or 2 years. How to do follow up of high grade BUR in your office practice? This is also very, very important slide, that you have to check for blood pressure, proteinuria with the help of urine protein creatinine ratio, kidney size on ultrasonography, and renal function test. All those patients who are having grade 3, 4, or 5 acid uric reflux. So my take home message from today's talk on pediatric UTI fresh updated guidelines for ISP and CON will be: urine collection techniques plays a really important role. You have to advise them how to collect urine, how to transport it also. Second thing, no need to do MCU in all patients less than 1 year of age, which was the guideline previously. But again, those who require, you should also have proper counseling of a parents that, okay, this is good for the kid, so you should go with the procedure. No need to treat asymptomatic bacteria unless you are planning for some urological procedure. No need to continue chemoprophylaxis till 5 years of age in all children with reflux. You should be, ultimately you are leading to antibiotic resistance, so it should not be continued till forever. Bowel bladder dysfunction needs special attention because of bad more of screen time, bad junk food. School, especially the school age girls, they don't like to use washroom of school, so they won't use it, and all this leads to a very bad behavioral vicious cycle, leading to constipation as well as UTI. So it needs special attention in your day-to-day practice. You have to ask for history of constipation in all patients. Surgery should not be offered as a first line of treatment without trial of chemoprophylaxis, unless in very certain cases, which are depending on the case-to-case basis. And reflux nephropathy requires periodic checkup for blood pressure, proteinuria, ultrasonography, and renal function test. And still, I want to say that guidelines are there, but each case is different. So sometimes you need to think like in whom to apply guideline to what extent, and you should take help of an expert for the same. Thank you. So that's me.
Yeah. You can stop the screen sharing.
Yes, sir.
Yeah, excellent as usual, Jalpa. You made a very comprehensive presentation on the newer guidelines. We always look forward to newer guidelines, especially for UTI, because
Yes.
things do change with the more studies available. And especially when these guidelines came up, it was very difficult to go through them because it runs into several pages, I think
Yes.
25 or more than that.
25 or
For,
more.
sorry?
Yes, sir. It is a lengthy one with all
Yeah,
the
it's very lengthy one because it has covered everything.
Yes, sir.
So this presentation actually will go a long way in guiding the pediatricians with some very good crisp carry-home messages, especially less use of prophylactic antibiotic and
Yes.
less use of invasive investigation like MCUG. So thank you very much. Uh,
Yes.
can you elaborate on what is bladder diary? Because we always talk about it, but not many pediatricians are actually using bladder diary. So what
Yes.
exactly are the parameters that one should know monitor
Yes.
in bladder diary?
Yes, sir. So, ideally, a bladder diary should contain, like I asked them, make a column. So, time, then water intake. So, how much water, like whether it is 100 ml, 200. Usually, they do have glasses which they know the measure of that glass. So, the baby wakes up at 7 o'clock, he has this 100 ml of water. Then, again at 3 o'clock, he is like whatever, 10 o'clock, he has this much amount of water. At the same time, another column for time and urine output. So they need to measure each and every time how many times they are going for maturation and how much urine they are doing. So there are containers available on medical store, or if you, what I say, especially all those who are coming from periphery, that if they have a bottle of say 250 ml or so, then they can ask, and it's very cumbersome to mature it in a bottle. But they can ask the kid to mature it in a wide mouth tumbler or something, and they can measure it via dipping into the bottle that okay 20 ml. I don't need okay 25 ml, 26 ml, but at least a gross idea whether the baby is passing only 10, 15 ml or is passing 250 ml. So time when the baby has passed urine and how much. Along with that, if those kids who have some history of incontinence, so leaking, another column for a leaking thing, if there is any leaking episode was there or not, whether the baby has wet pant during the daytime. So, and another column for constant like bowel evacuation, whether the baby has evacuated bowel on that day or not. Ideally, what they say is minimum 7 days voiding diary is ideal, but it is not practically possible. So, but at least what I tell them, minimum 48 to 72 hour of a diary, because many a time one day cannot decide about the whole thing. So,
Hmm.
especially on weekends, most of the kids have holiday nowadays on Saturday as well. So on Saturday, Sunday, they can make a voiding diary. So it will give us so how much water he has drank in 24 hours and how much time he has passed urine and how much in amount. So if it is very frequent voids with less volume, then it is kind of an overactive bladder. If it is say the baby has passed morning 400 ml and then at evening directly, then it's a underactive bladder. So all this thing we want in a voiding diary.
Right.
And especially the first void is also very important because first void is usually more because they have hold back throughout the night and also all these measures are there in voiding diary.
This helps a lot in enuresis management also.
Yes, sir. Yes, sir. And along with the diet, like what diet they are taking, whether it is more of junk and stuff. Yes.
Any comments or questions from other audience?
Uh, Jalpa, you have made good sketches. Satish, we must have noticed that she made
Yes,
some nice
we are very
sketches.
used to sketches by
Yes.
Jalpa and Anand now.
Yeah.
They do it so beautifully.
How frequent is this reflux incidence, vesico-ureteric reflux? Because I see that in our operation list.
Yes, sir. So, like especially if you see that almost 20 to 30% of like 30 as high as 30% of patients presenting with UTI can have reflux. The grade can
Oh.
vary. Yes, sir. And but nowadays, initially it was like all patients should go for reimplantation, whether it is once the grade is grade 3 or 4, you should okay operate the kid. But nowadays, with the terminology and more advanced in the congenital reflex dysplasia, and over a period of time they have found that ultimately doing a reimplantation earlier if the baby don't have any episode of UTI won't help in prevention of scarring. So nowadays we are more on a conservative approach rather than a direct surgical approach on the first visit itself. So, but yeah, it is very common. And if I say almost all those end stage renal disease, like in pediatric, they almost 20%, 20 to 30% are because of this reflex nephropathy, like up to 7 to 20%.
The gel injection is being used.
Yes, sir. It is for last 2 3 years. It was so initially they used to use this Dexel one, but it was not so frequently deflux. So it was not frequently available for last 2 3 years. But now they have another substitute, so it is being used. The only drawback is it's a bit expensive because even 1 ml can cost as 50 to 80,000, and another it's not a permanent one, sir. So sometimes, over it, you may need revision say after 3 years or so in case to case basis. So if cost is not an issue and if relatives want that they don't want to go with the surgery scarring and the long hospital stay because of that, you can advise them. but you have to explain that it is not permanent. The results depend on the grade of reflux. So if the reflux is grade 4 or 5, the result, the efficacy is only 70 to 80%. And for low grade reflux, definitely any which way low grade reflux are not going to have much trouble. So for grade 1 or 2, the like efficacy is good as high as 80-90%. But again, sir, it depends on case to case basis. What parents want, if they don't want, go for the open surgery and all, then they can choose it. But it has to be used judiciously and after explaining the nature of the further thing.
So if there are no more questions, I think we can end the session here. Thank you very much, Jalpa, once again.
Thank you.
It was wonderful to listen to you with all the guidelines. You have made it so comprehensive that we can go away with the lot of messages which we will be able to implement right away now. So thank you. Thank you all for joining.